cystic fibrosis presents as bilateral polyposis in children. Okay, in children, when you are having bilateral polyposis, this is the first diagnosis that have to come to your mind. Okay, why? Because it can be the early presentation of cystic fibrosis. In cystic fibrosis, there are other problems like pancreatitis and whatnot. You will have to learn it in detail in general medicine as well as pediatrics, and it is also known as mucoviscidosis. And why does it occur? It is due to the mutation in CFTR gene seen in chromosome 7, right? Chromosome 7. Okay, so that's about cystic fibrosis. Now coming to another condition which causes bilateral nasal polyposis in children, and what is that? You might have seen this movie, Dr. No, which is the first James Bond movie. Okay, this movie, the villain is what is known as Dr. No, and he has a history of being shot on the left side, but he didn't die. Why? Because he was having dextrocardia. Okay, dextrocardia. So there is a condition which is associated with dextrocardia along with nasal polyposis. What is that condition? When you are having dextrocardia along with nasal polyposis and bronchiectasis. Actually, it's not just dextrocardia occurring here, it is actually situs inversus. All the organs on the left side have gone to the right side. Okay, situs inversus, and along with that he is having polyposis. This syndrome is what is known as the Kartagener syndrome. Okay, this is what is meant by Kartagener syndrome, and this can result in bilateral polyps in children. Okay, so that's about Kartagener syndrome. Now coming to the other association, this is another association which is having more than 80% association, but the difference is that here it is unilateral and seen in adults. Okay, unilateral polyps which is seen in adults, and yes, this is something you have already seen, right? I already told you about a condition which is occurring due to a type 1 hypersensitivity to the fungal hyphae. What is that condition? It is none other than AFRS. Okay, you can see the typical double density sign here, right? And here you have the allergic mucin, right? And so this is AFRS, and AFRS is seen as unilateral in the adults, because whenever the fungal antigen is getting inspired, there is high chance that it can go into either of the maxillary sinuses, either right or the left side. Okay, if it is going to the left side, it results in left sidal AFRS. If it is going to the right side, it results in right side AFRS. It need not be the maxillary sinus, it can be ethmoid sinus. In fact, ethmoid sinus is the most commonly involved sinus in AFRS. Okay, so this AFRS is having more than 80% association with the polyposis formation. That is, if you are having AFRS, there is more than 80% chance that you are having a nasal polyp. Okay, and it is typically unilateral and seen in adults. Okay, so that's about AFRS. So we have learned about the various different associations, right? Now what are the associations that we learned now? We initially learned about allergic rhinitis. Yes, then we learned about the AERD or the Samter's triad, right? Samter's triad. And then we learned about Young's syndrome, and also about Churg-Strauss syndrome. Now all these presents as bilateral polyps in adults. Okay, bilateral polyps in adults. Now what are the causes of bilateral polyps in children? We learned about cystic fibrosis, right? Cystic fibrosis. And then what did we learn? We learned that there is a syndrome called Kartagener syndrome. Kartagener syndrome. Okay, and these are seen as bilateral polyposis in children. Now, unilateral polyps in adults, you have to think about AFRS and even bacterial sinusitis. Okay, chronic bacterial sinusitis. I told you about chronic rhinosinusitis with polyposis, right? When it is a bacterial chronic sinusitis, it can be unilateral, right? It is more likely to be unilateral because the bacteria can go and lodge in one side than going to bilateral. Okay, bilateral conditions are usually associated with something systemic. Okay, so chronic bacterial sinusitis. Okay, so that's in brief about the various association of nasal polyposis. Now coming to the various clinical features. The various features of sinusitis will be there because whenever there is edema in the area of the osteometal complex area and it is getting obstructed, that can result in sinusitis, right? And because of the sinusitis, there will be nasal obstruction, nasal discharge, postnasal drip. But this type of nasal discharge, which I already discussed, right, which is very thick and it can be pulled like a string, such a nasal discharge is typical of AFRS, right? And yes, AFRS is having more than 80% association with polyp formation. Okay, along with nasal obstruction, nasal discharge, postnasal drip, you can even have a headache, right? Headache can occur and sleep apnea can occur because of the obstruction. Obstruction is resulting in hypoxia, and because of that, the patient will be deprived of a proper sleep because the polyposis, when it causes nasal obstruction, it will be accentuated while he is sleeping at night, and so his night sleep will be affected, and that is what is resulting in obstructive sleep apnea syndrome. And of course, because of the hypoxia, he can have headache. Okay, and on examination, if the polyps are large enough, he can even result in a frog face like this. Okay, even proptosis can occur in the bilateral ethmoid polyp formation. Okay, so these are the various clinical features you have to know. That is nasal obstruction, then nasal discharge can occur, postnasal drip can occur. Okay, and along with that, there will be facial pain and headache. Headache is a typical feature of sinusitis, right? And if it is acute sinusitis, you can elicit the tenderness, right? Okay, facial pain, headache will be there. Obstructive sleep apnea can occur, okay, because of the obstruction. And what else can result? You can even have a hyponasal voice. Okay, hyponasal voice. And what is that known as? It is called as rhinolalia closa. Okay, rhinolalia closa can occur. Okay, so that is about the polyposis. And when you are having a unilateral nasal polyp in children, I told you about unilateral polyp in adults, right? It can be chronic bacterial sinusitis or AFRS. In children, when you are having unilateral polyp formation, then you have to think about one condition which I told you is now considered as a separate entity. And what is that? Yes, that is resulting in a dumbbell-like formation. And what is that? It is none other than the Antrochoanal polyp. Okay, Antrochoanal polyp. This Antrochoanal polyp arises from the maxillary antrum, and it has got three parts: the antral part, the nasal part, and the choanal part. So initially it is seen within the antrum like this, and then there is the narrow part, which is the neck part, which is seen within the nose, and in the choana there is a lot of space to expand, and because of that it will be filling the whole of the posterior ear of the choana, and that is what is meant by Antrochoanal polyp. And this Antrochoanal polyp will be growing backwards, and you will be able to see it as hanging behind the uvula. Okay, it will be seen as hanging behind the uvula, and it is typically dumbbell shaped. Okay, doesn't it look like a dumbbell? Because there are two larger areas with constriction in between, which is formed by the nasal part. The antral and the choanal part are very wide and large. Okay, so that is why it is dumbbell shape. So that's about the antrochoanal polyp, and this antrochoanal polyp is typically seen in children. Okay, it will present as unilateral nasal polyp in children. So when you are having a unilateral nasal polyp in children, you have to suspect a antrochoanal polyp. Now coming to the investigations that have to be done in case of a polyp formation. Okay, whenever a patient comes to you with features of sinusitis, what will you do? You will first of all take an X-ray, right? Yes, X-ray can be taken, and now what are the various differential diagnoses that you have to consider when you see a patient with nasal polyposis? If it is an infant, any nasal polyp, you have to consider the diagnosis of the meningocele or glioma. And how can you differentiate between a glioma and a meningocele? First of all, what is this meningocele? In meningocele, what is happening is that there is a skull base defect and the brain tissue. In meningocele, only the dural layers are getting herniated, whereas in case of the meningoencephalocele, the intracranial contents are also getting herniated through the skull base defect. Okay, so first of all, meningocele, where the meninges gets herniated through the skull base defect. Okay, if brain tissue present, then that is what is meant by meningoencephalocele. Okay, meningoencephalocele. So you have the defect like this. Okay, this is the skull base, this is the defect, and you have the various. Okay, this is the brain tissue. Okay, if only the meninges is coming out, it is called meningoencephalocele. If along with the meninges, if you have the brain tissue as well, okay, in that case, then it is what is meant by meningoencephalocele. Okay, now in certain conditions, what happens is that this stalk, it gets obliterated. Okay, so in that case, what happens is that there will be a nasal mass, but there won't be any connection with the intracranial contents. Okay, so this thing, when you are having a nasal mass over here like this, this is the thing, and you are having a nasal mass, it has come out like this, but this stalk is not there, it has got obliterated. Okay, in this case, this is what is meant by glioma. Okay, now how will you differentiate a glioma from a meningocele? This can be done by a test. What is the test? That is called Furstenberger's test. In Furstenberger's test, what is happening when the child is starting to cry, or when you are applying pressure on the jugular vein, what happens is that due to the increase in intracranial pressure, you will be able to see that the mass is getting further herniated. Okay, that is what is meant by a Furstenberger's test. If the Furstenberger's test is negative, then it is a glioma and not a meningoencephalocele or a meningoencephalocele. And in case of meningoencephalocele, there will be this, when you are doing a transillumination test, it will be positive. Okay, transillumination test will be positive. And what are the other differences? You have the meningocele here, this is the glioma here. Okay, and meningocele is soft and compressible. Okay, meningocele is soft and compressible, whereas glioma is firm and non-compressible. And when you do Furstenberger's test, it will be positive. Here it is negative. And what else? When you are doing another test, that is transillumination test, that will be positive here in case of meningocele. Here transillumination will be negative. Okay, so that's about difference between a meningocele and a glioma. Now, when a child is presenting with unilateral mucopurulent rhinorrhea, what is the condition that you have to suspect? Is it antrochoanal polyp? I told you antrochoanal polyp can be unilateral, right? But no, that is not the condition that you have to suspect. The first diagnosis that has to come to your mind is foreign body of the nose. Okay, foreign body of the nose. It is very, very common for a child to keep a foreign body within the nose, and the child will be presenting with typical history of unilateral putrid nasal discharge, and when you examine, you will be able to see there is a foreign body like this. If it is not an impacted foreign body, you can actually remove it from the OPD itself. And yes, if the foreign body is a button bacteria, there is high risk of it getting excoriated, and there will be nasal deformity occurring like Lord Voldemort, right? Okay, so that is the importance of removing the foreign body very soon. Okay, you can't wait with the foreign body button battery. And yes, when a child is having a foreign body in the nose, you have to remove it. Okay, it has to be removed very fast. Now, what are the options given here? You can present with unilateral fetal discharge, that is true. Presence with unilateral nasal obstruction, true. Can it cause torrential epistaxis? No. When you are removing the foreign body, there will be epistaxis, but otherwise it is unlikely. Inanimate is more common than animate, that is true. Always removed under GA? No. When will you need a GA? If you find it difficult to remove the foreign body, when you are removing it from the OPD, how will you usually remove? It is done with a process Eustachian tube catheter, which is used for catheterization, is usually used for this purpose as well. Okay, when you are using a Rose's Eustachian tube catheter and trying to remove the foreign body, and when it is not possible to remove the foreign body, in that case, what will you do? You will go for a general anesthesia. So it is strictly restricted to foreign bodies which are impacted. Okay, impacted foreign bodies. But I think in Western countries, they don't try such heroism. They directly give a GA to the child, and they will remove it only under GA, because the trauma elicited on the child when you are trying to remove the foreign body, the child will of course resist when you are trying to remove a foreign body, right? So you will have to bind him, you will have to mummify him, and yes, you can remove it with the help of suction and everything, but the most commonly taught method is when you are restricting the child in the sitting position, you use the Eustachian tube catheter and remove it. But this thing will be something which causes a lot of trauma to the child, and hence it is preferable to remove it under general anesthesia. But yes, of course there are risks of GA, but yes, it is preferable to remove it under general anesthesia. Okay, now when there is something like this in an adult patient who is about 40 to 50 years, then you have to consider the diagnosis of inverted papilloma. Okay, inverted papilloma is another condition that has to be considered. Okay, inverted papilloma, or it can even be a sinonasal malignancy. Okay, sinonasal malignancy also can present like this. Okay, and yes, it could be a tumor. Okay, if it is a bleeding nasal mass in a child, an adolescent, a male child, in that case you have to suspect juvenile nasopharyngeal angiofibroma. Okay, I have seen CT reports of juvenile nasopharyngeal angiofibroma as written as polyposis. Okay, there are typical findings in case of JNA, which you will be learning later on. The pterygoid plates will be eroded. All those typical signs were there in that CT, and still it was reported as sinonasal polyposis. So you should never ever just blindly trust the report of a radiologist. You have to go through the CT scans yourself. You will have to have a an entire idea of how to look at the CT scan if you are being a ENT surgeon. Okay, and so that's about. And then now what do you see here? You can see that the middle turbinate is air filled, right? This is an air filled middle turbinate. Now this air filled middle turbinate, where have you seen? This is what is meant by a conga bullosa. Okay, conga bullosa. Okay, this conga bullosa can also mimic a nasal polyp. Okay, and in this case you will have to do a partial middle turbinectomy, because this conga bullosa can result in sinusitis by blocking the osteometal complex, right? So you will have to do a partial turbinectomy for that. So it is also a differential diagnosis, and in fact sometimes the parents may bring the child to you saying there is some polyp here. Even general practitioners refer cases to you saying there is a polyp in the nose, but it could be an inferior turbinate hypertrophy. Okay, I already told you the difference between inferior turbinate hypertrophy and middle turbinate hypertrophy, right? Okay, inferior turbinate hypertrophy also may be suspected for a case of a nasal polyposis. Okay, so these are the various differential diagnoses that you have to consider. That is, what are the things I told you? Meningocele, glioma. Okay, glioma. Now meningocele can have CSF leak. Okay, along with that the patient can have recurrent meningitis. All such problems are not there in case of glioma, which can be intranasal, extranasal, etc. Okay, whereas this meningocele is occipital usually, or occipitofrontal. Okay, now what are the other differential diagnoses? Yes, foreign body nose in children. Then in adults, what else you have to think about? In adults, you have to think about inverted papilloma, malignancy, JNA in adolescents. Okay, JNA in adolescents. Then you have to think about conga bullosa, inferior turbinate hypertrophy, right? Okay, all these are the various differential diagnoses that you have to know about. Okay, so finally I told about conga bullosa, inferior turbinate hypertrophy, and of course you have to think about sinonasal malignancy as well. So in a long-standing case of polyposis in an adult, first of all you have to rule out inverted papilloma. Okay, because when you are moving the inverted papilloma, the polyps, there might be polyps, of course, because of the inverted papilloma obstructing the osteometal complex. It can result in polyp formation, that will be present, but there will be the typical mass of inverted papilloma. If you are removing the polyp, it might be seen. Okay, so you have to take a biopsy in all those cases. Sinonasal malignancy. Okay, so coming to the various investigations that have to be done in case of a patient who present with polyp formation. Before the advent of CT scan, what used to be done was an X-ray nasopharynx lateral view was taken, and we used to look for if the crescent of air was seen behind the nasal mass. If there is a crescent of air, as you can see here, if it was seen, then that is indicative of crescent sign being positive, and it is seen in nasal polyposis. Okay, crescent sign or dot sign positive is seen in nasal polyposis, and if it is negative, it is indicative of a nasopharyngeal mass, as in JNA or a CA nasopharynx. Okay, so that's how this X-ray was taken to differentiate it from a polyp or a nasopharyngeal mass. Okay, and then an X-ray PNS Waters view was taken to look for if there is any bone erosion apart from the haziness, which can be seen in a case of sinusitis as well. Okay, and you will be looking for a regular shaped mass which is causing a bone erosion. If there is bone erosion, you have to suspect a malignancy. Okay, and Yes, nowadays you have diagnostic nasal endoscopy, which is now considered as part of clinical examination itself, and 0° and 30° nasal endoscopes are used. With that, you will be looking for the polyp, which will be seen as arising from the middle meatus area in most cases, because it is the area of the osteomeatal complex. And what are the things you look for in CT scan? Yes, you have to take an NCCT, that is the investigation of choice for nasal polyposis nowadays. Okay, nowadays there is no X-ray being taken, you straight away go for NCCT, non-contrast CT scan, and this non-contrast CT scan is the investigation of choice. And what are the things that you look for? You will be looking for where all the polyps are seen. As you can see here, the polyps are seen in the maxillary sinus and the ethmoid sinus in the right side. And apart from that, you will be looking for the lamina papillaris if there is any dehiscence, or in the cribriform plate of ethmoid, what is its depth. Okay, you will be looking for the Kiros classification, the depth of the olfactory fossa is also look for, and yes, you will be looking for onodicels and the if there is any dehiscence in the sphenoid sinus. All these things you will have to look for when you get a NCCT. Okay, so the investigation of choice nowadays is non-contrast CT scan. And when will you do a contrast and CT scan? If the patient is presenting with epistaxis, you will have to suspect a mass which is vascular like JNA. In that case, you have to do a contrast and CT scan. Otherwise, NCCT is more than enough. Okay. So the investigations nowadays being done are, and of course diagnostic nasal endoscopy, then you have to do an NCCT, nose and PNS. Okay, absolute eosinophil count may be done. Okay, because nowadays the biological treatment are also being introduced, and if you are going for a biopsy when you are suspecting a malignancy in case of elderly, the biopsy specimen also can be given for looking for eosinophils. Okay, so biopsy can also be done as a part of investigating the lesion. Okay, now what is the treatment of a case of nasal polyposis? First of all, you have to go for medical management, right? Yes, what is the medical management? You will give for topical steroid spray. It is not introduced into the mouth as you saw here, it is introduced into the nasal cavity. Okay, so intranasal steroids. Okay, what are the various intranasal steroids available? It could be a fluticasone propionate, fluticasone furavate, fluticasone propionate or furavate. And then what else do you have? You have mometasone nasal spray, which is given in the children who are less than 2 years old. You can't give steroid spray at all. Okay, 2 to 4 years you can give mometasone nasal spray. Give mometasone nasal spray. These are the various steroid nasal spray given. You can do a medical polypectomy to prepare the patient before the surgery. Okay, and how is it being done? You are giving oral steroids for medical polypectomy. Prednisolone is given at the dose of 0.5 mg per kg per day, and it is given for about 21 days. Okay, it is given for 21 days. Now you have to remove the polyp, right? For that you will have to go for functional endoscopic sinus surgery. Okay, and ideally you have to use a microdebrider, because just debulking it will be difficult and there is more chance of recurrence when you are doing like that. Okay, you have to use a microdebrider, which is a powered instrument with a shaver, which can help you remove the polyp very easily. Okay, and here you can see a navigation being used. Okay, that is image guided surgery that is being done. Image guided surgery. Okay, here the CT scan is taken. Along with the CT scan, you can correlate and then do the surgery. That is the idea behind this image guided surgery. And yes, when you are doing an image guided surgery, there are certain indications. It is usually done for sphenoid sinusitis, posterior ethmoid sinusitis, if it is a recurrent polyposis, extensive polyposis. Okay, when there is any history of previous surgery, if it is a revision surgery, in all these cases it is ideal to use a image guided system for doing the surgery. Okay, and this image guided system provides a roadmap. Okay, you will know exactly where in the CT scan you are while doing the surgery itself. That is the importance of this image guided surgery. But however meticulous you are, there is high chance of recurrence. Okay, because these ethmoid polyps are notorious for recurring, and yes, it is very important that you keep the patient under follow up and do diagnostic nasal endoscopy even after surgery. And the patient should be on steroid nasal spray. The role of surgery is not just to remove the polyp, but it also provides a pathway for the nasal spray to reach. Okay, if the intranasal spray has to reach the middle meatus and act on it, you have to remove the polyp properly. Okay, now in which of the following situations there is no need of using a postoperative steroid? Post-antrochoanal surgery, allergic rhinosinusitis, post-fungal sinusitis surgery, multiple ethmoidal polyps. The answer is post-antrochoanal surgery, because antrochoanal polyp, what did I tell you about antrochoanal polyp? It is seen in children, right? Unilateral antrochoanal polyp, it is seen in children. It is actually due to an infection in the maxillary sinus, and this is resulting in OMC block, and because of that, along the sinusitis, there is protrusion of mucosa resulting in formation of AC polyp. And if you remove the AC polyp, usually it does not recur. Okay, and there is no need of a postoperative steroid in case of AC polyp. Okay, now there are certain differences between an AC polyp and ethmoid polyp that are always asked during your viva. Okay, so you have to remember that. What are they? First thing, I already told you, it is more commonly seen in children, antrochoanal polyp, whereas ethmoidal polyps are seen in adults. Etiology of AC polyp is infection. Okay, ethmoidal polyp, it is multifactorial. I told you the various association of ethmoidal polyp, right? And it is single because it is coming from maxillary sinus in case of antrochoanal polyp, whereas it is multiple, coming from multiple ethmoidal hair cells. So it is multiple in case of ethmoidal polyp. Laterality, it is unilateral in AC polyp because it is infection which is causing the same, whereas ethmoidal polyp is usually bilateral because it is multifactorial. There are various causes of ethmoidal polyp to occur, and origin is from maxillary sinus. Here it is from ethmoidal sinus, and this is very important. Okay, the antrochoanal polyp is growing posteriorly. Okay, it grows posteriorly. That is why there is an antral, nasal, and choanal part, and the choanal part is seen behind the uvula. It is growing posteriorly, whereas ethmoidal polyp grows anteriorly. It grows anteriorly. Here it is dumbbell shaped, whereas it is grape shaped in ethmoidal polyp. Recurrence is uncommon, and the treatment is mainly surgical in case of AC polyp, whereas ethmoidal polyp it is common and mainly the treatment is medical. So even after the surgery, you will have to go for continuous nasal spray in case of ethmoidal polyp. Okay, so that's all about polyposis, and let me revise the things that we already discussed today. First of all, what did we learn? We learned about the various etiology and pathogenesis behind polyp formation. We learned about the Bernoulli's phenomenon, right? Bernoulli's phenomenon, which is resulting in the protrusion of paranasal sinus mucosa as nasal polyp, and this is occurring because of the edema in an area where there is inflammation occurring, and this inflammation can be due to an allergic cause or a non-allergic cause. And we learned about the various association with the CRS with polyposis, right? What are the various association? We learned how in adults you have to suspect an allergic rhinitis, AERD, or aspirin exacerbated respiratory disease, okay, AERD, which is also known as Samter's triad. Okay, Samter's triad, that also you have to suspect in case of adults. Okay, and it will be bilateral. And then what did we learn? Young syndrome. Young syndrome is one condition where there is azoospermia along with nasal polyposis, and along with that you will be having bronchiectasis, right? Bronchiectasis. And of course, when there are other systemic manifestations like myocarditis, peripheral neuropathy. In that case, you have to think about EGPA, eosinophilic granulomatosis with polyangiitis. In children, you will have to think about, what is the first thing you have to think about? You have to think about cystic fibrosis. When it is bilateral, cystic fibrosis has to be thought about. And then what else you have to think about? Apart from cystic fibrosis, which is also known as mucoviscidosis, you have to think about the Kartagener syndrome. And unilateral polyp in adults, you have to think about bacterial sinusitis, AFRS. Whereas in children, you have to think about the condition AC polyp. Now you have to always think about the various differential diagnoses, like the encephalocele in case of infants. It is very important that you don't forget the encephalocele part while seeing a polyp in case of children, and yes, Furstenberg test will be positive. Furstenberg test will be positive in case of infants when you are having an encephalocele. And of course, when there is encephalocele, you have to go for a CT and an MRI, and you have to know the exact extent. You have to excise the encephalocele and close the defect, otherwise there will be CSF leak. CSF rhinori can occur. CSF rhinori will be dealt with separately in another session. So these are the main things that we learned. Then we learned about the various investigations that are done and the treatment of polyposis. So that's all for today. Please go and read today itself. I will be coming with another session. For now, goodbye.